In this video, we're going to look at SLE, which stands for systemic lupus erythematosus. And like the name entails, it's going to affect different systems of the body. And the way I kind of like to think about SLE is you have the body mounting or launching an attack onto the body. So you just have the body attacking itself. Now, this topic, to kind of make it short, I will divide it into different videos. So in this first part, we're just going to look at some of the causes and a brief touch on the pathophysiology. The next videos will follow just like that. So coming to what's causing SLE, we can start on the side of genetics. When it comes to genetics, we are mainly interested in the human leukocyte antigen DR2 and HLA-DR3. I kind of like to think of it as HLA Dr. 2 and Dr. 3. So this is responsible for how the body IDs itself, how the body identifies itself. If you have a cell and the antigens that are present on it, how will the body know that this is part of itself? It's through various mechanisms, and one of it is through this HLA Dr. 2 and Dr. 3. So people with SLE have a defect here, and so it means that even how the body will be able to identify certain things will be a little bit messed up. And like we said, for SLE, you're thinking about the body launching an attack on itself. It will obviously mean that for certain things, it means the body won't necessarily be able to identify that it's attacking itself. So that's the first thing. The other thing that will be important will be complements. So we are thinking about C3 and we are thinking about C4. The other thing that will be important in the pathophysiology of SLE will be environmental factors. Some of those things that we'll be looking at will be things like drugs. The drugs we're mainly interested in will be procainamide, hydralazine, and isoniazid. These drugs have been shown to induce some sort of SLE. Viruses such as the Epstein-Barr virus also have been shown, and also hormones. Now, when we're dealing with hormones, the main hormone we're interested in mostly will be estrogen. And so this is why when we are dealing with SLE, it will be more common for you to notice that a female has SLE as compared to a male having SLE. Mainly because of the hormones, and it will be common in women who are of childbearing age. And lastly, another thing that will be common in the whole pathophysiology and causing SLE will be UV radiation, specifically sunlight. So patients who have SLE, it will be a common thing for certain triggers like sunlight to cause this whole cascade of events. So just to repeat, we were dealing with HLA, Dr. 2, Dr. 3, a reduced amount of complements, viral infections like the Epstein-Barr virus, drugs such as procainamide, hydralazine, isoniazid, UV radiation, and hormones. Okay, so to just briefly touch on the pathophysiology of what's happening, we have a person who is being exposed to UV radiation in the form of sunlight, and this UV radiation is causing cell death. It's leading to apoptosis. Now, under normal situations, let's say this is our cell, the cell is going to have intracellular material, say genetic material, and different things. When apoptosis happens, this cell is going to rupture, and the intracellular material is going to be expressed extracellular. So outside the body, outside of the cell, we are going to have things like phagocytes, things like macrophages that will come and engulf this material. And of course, the body has complements to kind of increase the rate at which this genetic material is cleared. This is what's happening under normal situations. Now, people with SLE, remember that we said that they have lower amounts of complements. So it means the rate at which this process is taking place has massively increased. And if this is happening, well, we are starting with the antigen presenting cells such as the macrophages trying to clear up. Remember that this material is not being cleared up fast enough. So it means this is being presented to T cells. And the T cells will activate different cells, the B cells, plasma cells. All in all, it's going to lead to antibodies which will be formed. And these antibodies are formed against our own nuclear material. So we are having anti-nuclear antibodies that are being formed. Now, these antibodies can then begin to attack the cell. But remember that the body has got ways of identifying itself. Remember the human leukocyte antigen, Dr. 2 and Dr. 3. But this one is messed up in SLE. So it means these anti-nuclear antibodies that are being formed can then go and begin to attack the body. So this is how the lack of complements and this whole IDIN system is ultimately leading to the body beginning to attack itself. I believe repetition is a teacher of all masters. So when we're dealing with SLE, we're saying systemic lupus erythematosus, we are just thinking of the body launching and mounting an attack onto itself. Things that can trigger it, we've said viral infections, certain drugs, UV radiation, certain hormones. All in all, these will be triggering points leading to massive apoptosis. Now, in clearing this genetic material, complements such as C3 and C4 will be important, but patients with SLE have been shown to lack these complements. And on top of that, they are lacking an IDIN part known as HLA, Dr. 2 and Dr. 3. So all in all, antibodies are going to be launched and will attack the body. So this was the first part on SLE. Thank you for watching this video. Peace.